The next topic where Dr. Kiran ma'am would be talking about would be the concept of ocular perfusion pressure.
Good morning, everyone. So theories for pathogenesis of glaucomatous optic neuropathy, have been mechanical, vascular, and neurogenic. But the existence of normotensive glaucoma cannot be explained by a pressure theory alone. So there was a new pressure for the glaucoma specialist, the ocular perfusion pressure. What is OPP? In its simplest form, it is the relationship between systemic blood pressure and intraocular pressure. Van Jager was the first to suggest a vascular etiology for pathogenesis of glaucoma. It attempts to explain on the basis of a reduced ocular perfusion pressure, a faulty vascular autoregulation, and loss of neurovascular coupling. OPP is the pressure at which the blood enters the eye and is defined as the difference between the arterial and venous pressure in the eye. As venous pressure in the eye approximates a IOP, IOP can be considered a substitute for the venous pressure. So OPP can be expressed as the difference between arterial blood pressure and intraocular pressure. So the normal blood pressure variation is usually 40 to 60 millimeters in a cardiac cycle, while typical circadian variation in IOP is around 5 to 8 millimeters. So the perfusion pressure changes, but the tissue blood flow should remain stable to maintain metabolic activity. Good perfusion depends on complex regulation process that balances the BP and IOP. Adequate perfusion with sufficient blood is critical to maintain the metabolic and nutritional needs. So by definition, ocular perfusion pressure is defined. It refers to the pressure available to drive blood through the intraocular vasculature, the degree of perfusion being influenced by resistance to flow, which is a function of the vessel caliber or vessel tone. Decrease in OPP and or subsequent ischemia of the optic nerve head could contribute to the glaucomatous optic neuropathy. Decreased OPP is a risk factor for prevalence, incidence, and progression of glaucoma. Death of the retinal ganglion cells is enhanced by the reduced OPP, and abnormal autoregulation and neurovascular coupling may lead to the ganglion cell death. OPP can be defined as the mean OPP, systolic and diastolic ocular perfusion pressures. What is the mean OPP? It is 2/3 mean arterial pressure minus IOP, where mean arterial pressure is diastolic blood pressure plus 1/3 systolic BP minus diastolic BP. This 2/3 accounts for the drop in BP between the brachial and ophthalmic artery when the subject is seated. So systolic ocular perfusion pressure is systemic systolic BP minus IOP, and diastolic ocular perfusion pressure is systemic diastolic BP minus IOP. DOPP is especially useful in displaying the lowest OPP values. So regardless of the calculation method used to define OPP, it is clearly reduced in the presence of low blood pressure, high intraocular pressure, or both. Now because blood pressure is a much greater than IOP, changes in BP affect OPP to a greater extent than changes in IOP. Furthermore, BP and IOP both follow circadian rhythm from day to day, within day, daytime, nighttime, and BP within each cardiac cycle. So OPP is therefore highly variable and prone to fluctuation. Now OPP itself includes IOP, so it is possible that some of the findings attributed to OPP are in fact secondary to IOP. So it is important to check whether the results of a study were adjusted for intraocular pressure, anti-glaucoma, and antihypertensive medication. It was observed that adjustment was available in only 57% of our studies. There's a strong association of open-angle glaucoma was found with low ocular perfusion pressure, low diastolic blood pressure of less than 60, and a high systolic BP of more than 170. So both extremes of BP spectrum are at a greater risk of glaucoma. So what is the hypothesis? A low diastolic pressure, the patients suffer from low OPP at the optic nerve head. With a high systolic BP, there's a decrease in the vessel diameter and arteriosclerosis, which compromises the vascular autoregulation and impairs nutrient exchange at the optic nerve head. So this hypothesis indicates that low low OPP can occur secondary to a high intraocular pressure, low or high BP, and atherosclerosis. Now, systolic and diastolic BP declines or dips during sleep between 2 and 4 a.m. due to decrease in sympathetic system activity during sleep, which is a normal physiological dip. Now, there are some patients who are non-dippers if the nocturnal decline is absent or blunted, and some are extreme dippers if the nocturnal fall is greater than 15 to 20%. So it was seen that lack of physiological dip may be harmful, may result in an impaired microcirculation, possibly associated with excessive free radical production, toxic to neurons or glial cells. Now, blood flow is autoregulated to maintain a constant flow despite fluctuations in perfusion pressure. Autoregulation of ocular blood flow is characterized by local vascular constriction or dilatation, causing an increase or decreased vascular resistance, thereby maintaining a constant nutrient supply in response to the perfusion pressure changes. But the relationship between OPP and ocular blood flow is complex. An autoregulation response may differ if the pressure is altered through arterial or venous pathway, particularly due to paucity of smooth muscles in veins. It was seen that abnormal autoregulation occurs in glaucoma in response to acute changes in the ocular perfusion pressure, which could be due to change in body position leading to changes in circulatory system, and short-term rise of IOP leads to reduced retinal vessel reaction in POG patients. So even in the presence of autoregulation, low OPP predisposes for ischemic periods by reducing the range of the autoregulatory reserve. So low systemic BP combined with elevated IOP will reduce the OPP at the optic nerve head, reduce blood flow volume in eyes with an impaired autoregulatory system, leading to ischemic damage to the axons and atrophy of the retinal ganglion cells. Now, OPP is a complex variable that could be affected by multiple factors, and neither BP nor IOP can account entirely for its regulation, like a postural change. IOP increases by 3 to 4 millimeters at night in a supine position, and there is increase in the episcleral venous pressure. There is a diurnal rhythm both of BP and IOP. Oral antihypertensive medications cause nocturnal hypotension as a combined effect of antihypertensive and natural diurnal rhythm. So should be a cautious use of antihypertensive with progressive visual field deterioration despite low IOP is advised, and topical anti-glaucoma medications. Now, loss of autoregulation in the ocular blood flow resulted in, it was seen there was a greater increase in NRR blood flow were observed in POG patients than in ocular hypertensive with similar amount of IOP reduction, and MOPP, that is the mean ocular perfusion pressure, correlated positively with end diastolic velocity in the ophthalmic and central retinal artery in progressive glaucoma patients. Such correlations were absent in stable glaucoma patients and healthy controls. Now, vascular dysregulation is hypothesized to be involved in at least some cases of glaucoma, especially in normotensive glaucoma. So it could lead not only to chronically low perfusion, but to unstable perfusion with wide fluctuations and repeated ischemic stress, leading to the optic nerve head injury. Vascular dysregulation appears to be an early manifestation in glaucoma, causing a reduced ocular nerve head blood flow, and there's an abnormal association between BP and ocular perfusion, which leads to unstable ocular perfusion and thereby to ischemia and reperfusion damage. Reduction in both OPP and ocular blood flow occurs during sleep in the supine position due to combined effects of a rise in IOP and dip of systemic blood pressure. So significantly lower DOPPs were seen in POG patients during the whole night from midnight to 6 a.m. And low nocturnal OPP might result in further damage in glaucoma patient, especially when autoregulation is impaired. Now, that was seen there's a circadian MOPP flow, which may be the most important risk factor for glaucoma. In addition to being important in NTG with nocturnal hypotension, it may have a role in development of glaucoma regardless of nocturnal hypotension. Excess free radicals derived from ischemia and reperfusion may contribute to reversible or irreversible manifestations of cell injury. it is hypothesized that chronic, repetitive, circadian ocular blood flow variations could result in accumulative ischemia and reperfusion effects manifested in the form of RNFL damage, that is, and visual field deterioration. In susceptible individuals, autoregulatory dysfunction allows any fluctuation in OPP via changes in BP or IOP to change retinal and optic nerve head perfusion. Atherosclerosis from prolonged arterial hypertension resulting in inadequate changes in vessel size, reducing reserve available for other challenges to the circulation, inherently abnormal vascular response to autonomic stimulation, local hormones and metabolites. A relationship between some atherosclerotic risk factors and OAG has been demonstrated in several studies, though no study directly visualized the ocular circulation in humans, highlighting the need for additional studies to identify the real influence of atherosclerosis in glaucoma. Now, what is the effect of medications on OPP? The American Heart Association recommends aggressive control of blood pressure less than 130/80 in patients with CAD and much lower in patients with left ventricular dysfunction. So it was seen that aggressive treatment of systemic hypertension was deleterious for glaucoma patients, and several studies suggested the influence of systemic hypertension on glaucoma. Harry noted that patients on topical and systemic beta blockers had greater nocturnal BP dips than other patients. The possibility that overtreatment of systemic hypertension could worsen the glaucoma. So a compromised vascular system can also influence glaucoma damage due to inability of the eye to maintain consistent and adequate perfusion during pharmacologically lowered BP in susceptible individuals. Low diastolic blood pressures due to antihypertensive therapy was associated with increased cupping, suggesting low BP and OPP can predispose to glaucomatous damage. Now, calcium channel antagonist may increase ocular circulation and protect neuronal cells against retinal neurotoxicity. However, the Rotterdam eye study revealed an increased risk of OAG with calcium channel antagonist. These agents decrease BP without affecting IOP, thus reducing OPP. So results suggest caution when using calcium channel antagonist in glaucoma patients. Now, effect of anti-glaucoma medications on OPP are variable. A mean 24-hour systolic BP and diastolic BP was significantly reduced by brimonidine and timolol. The mean 24-hour OPP with latanoprost was significantly increased. Timolol did not, possibly due to reduction in BP, and brimonidine induced a significant decrease in the mean 24-hour DOPP. Dorzolamide and latanoprost both induced a significant increase. So to conclude, glaucoma is more than just a disease of single type of description. Some assessment of ocular perfusion pressure also needs to be considered when determining an individual's risk of developing glaucoma or experiencing disease progression. Nighttime perfusion pressure could be a prediction of glaucoma risk. Systemic antihypertensive medication treatment could affect the risk of developing the disease and or its progression. Now, ocular perfusion pressure is subject to influence by a myriad of factors, and it is measured conventionally as the difference between mean arterial pressure and IOP. OPP has been identified as an important factor in development and progression of glaucoma, especially in NTG where autoregulation dysfunction has been implicated. An ambulatory 24-hour OPP may assist in efficacy of treatment and assess individual diurnal fluctuation. Interdisciplinary treatment of hypertension and glaucoma should be emphasized, and different medications to lower IOP have different effects on OPP. So we are currently aware that not all assumptions regarding vascular theory hold true. Other mechanisms, including those associated with biochemical and genetic theories, indicate several other factors can lead to glaucoma. It is assumed that glaucoma is a multifactorial disorder with multiple mechanisms active in the same patient. Further prospective longitudinal clinical and epidemiological studies should be conducted to conclusively prove the role of vasogenesis in causation of glaucoma and ultimately use that facet of pathogenesis in better management of patients suffering from this condition in a more holistic manner. Thank you.